Very good evening to all of you. Here today, we are at the day 2 of the National Symposium organized by RDIF. And this is in just the wake of the Rare Disease Day. Now, the International Rare Disease Day is a day where we celebrate to commemorate all the stakeholders who are actually related to rare diseases, to come forward with the awareness, not just in the community, not just with the clinicians, not just with the people who are affected, but also with people who are not affected. Because we need that awareness for more people to come forward and also for prevention. Now, in India, rare diseases are a disease which still we don't really have a definition, because each country has its definition of their own. But we have a very recent policy which actually states that we need to look at the registry to find these policies. Without wasting much time, I would actually introduce you to a huge group of panelists. It's a very celestial panelist which we have today, and who will be discussing on different aspects of these rare diseases to raise awareness. Before that, we would like Mr. Saurav Singh to say a few words on the recent state of rare diseases in India. If I have to introduce Mr. Saurav Singh, he is the co-founder and director of Rare Disease Foundation India. He's a father of a child who is suffering from MPS 2 or Hunter syndrome. He has done his MBA and worked for 15 years in various multinational companies. And he's the person who left behind everything to access treatment for his son, and also make access to many more patients in the country by formulating an organization called RDIF. We welcome Mr. Saurav Singh to say a few words on the context of rare disease in India.
Yeah. Good evening, everyone. I am Saurav Singh, founder and chairperson of Rare Disease India Foundation, RDIF. We are really very glad to see all of you here on this special occasion of First National Symposium 2022, starting from 26th February to 28th February from 5:30 p.m. to 7 p.m. on Rare Disease Awareness Day. This is 3 days event which is organized by Rare Disease India Foundation. I would like to thank Sanofi, Symposium and LifeCell for supporting us for this cause. I wholeheartedly welcome all our eminent speaker, moderator and attendees today who are watching us from different corners of this world. I also thank our strategic partner, ECMERI. RDIF is a patient advocacy group. It is established in 2019. This is a non-profit organization which works for the benefits of the patients. All we know that rare disease is a very few in numbers. Mostly it is genetic. Only 6% to 8% of population of India is affected with rare diseases, and 72 to 96 million people affected by rare diseases. There are many challenges in rare diseases. Either there is no treatment available, or the treatment is unaffordable by an individual, which generally comes in crores. Another challenge is early diagnosis of these diseases. It is also one of the major challenges in rare diseases. Lack of awareness about rare diseases, including patients, medical fraternity, general public. Government does not fully support in these diseases. Families are bound to watch their person dying every day. We all know that. In the month of March 2021, the government of India has formulated a revised rare disease policy. But that too is not very much effective, especially for group 3 diseases, which includes lifetime treatment, but cost is very high. To discuss in detail about these issues, today we have the brilliant speakers of India who are treating rare disease patients. First of all, I would like to welcome our chief guest, Dr. Shefali Gulati from AIIMS New Delhi. Our keynote speaker, Dr. Nirja Gupta from AIIMS New Delhi. I also welcome our another speaker, Dr. Sunita Bizania from Sir Gangaram Hospital, New Delhi. Our another speaker is Dr. Divya Agarwal from Apollo Hospital, Indraprasth, New Delhi. We also have speaker, Lieutenant Colonel Dr. Aradhana Dwivedi from Army Hospital, Research and Referrals, New Delhi. And last but not the least, I welcome our moderator for the session, Dr. Dipanjana Datta from Institute of Child Health, Kolkata, West Bengal. So the purpose behind organizing this event is one and only, to spread awareness about rare diseases among the patient, families, general public and medical fraternity, and the decision makers also. So over to you, Dr. Dipanjana.
Thank you so much, Mr. Saurav Singh, for introducing me as well. I welcome all the speakers and especially our chief guest for today. And before we start, I would request everyone to please note that we have a patient video playing over here, because this is, we all have gathered here for the benefit of the patients. There will be a small video for the patients just to raise awareness. Thank you. The IT team might play the video now, please.
नमस्ते, मेरा नाम नेहा जवर है। हम फरीदाबाद से हैं। मेरे दोनों बच्चे केनेत और मिधांश, दोनों ही बच्चे म्यूकोपॉलीसेक्राइड्स 2 MPS 2 जिसको हंटर सिंड्रोम भी बोलते हैं, उससे पीड़ित हैं। हम जिसका कॉस्ट ऑफ ट्रीटमेंट इन करोर्स है। ये कोई भी इंडिविजुअल जो अफोर्ड नहीं कर सकता। हम डॉक्टर्स ने बोला है कि अगर इनको टाइमली ट्रीटमेंट नहीं मिला तो इनकी बॉडी कोलैप्स होने लग जाएगी, डिटेरियोरेट होने लग जाएगी, और अगर इनको ट्रीटमेंट नहीं मिलता है तो इनका लाइफ स्पेन भी अराउंड 10 to 12 ईयर्स है। मैं गवर्नमेंट ऑफ इंडिया से ये अपील करती हूँ कि जो पॉलिसी उन्होंने, रेयर डिजीज पॉलिसी जो उन्होंने बनाई है, उसमें वो इफेक्टिव अभी नहीं है। एक इफेक्टिव रेयर डिजीज पॉलिसी लेके आए जिससे जितने भी रेयर डिजीज पेशेंट्स हैं उनका टाइमली ट्रीटमेंट हो।
Hello. Yes, after watching the patient's video, we will shift on to the program for tonight. And I would welcome Dr. Shefali Gulati. She is the chief guest for us tonight. And ma'am is affiliated with the Child Neurology Division, Department of Pediatrics, AIMS, New Delhi. She's the President-elect, Association of Child Neurology, 2003 to 2005. She's the International Society. She's a member of the International Society of Autism Research Global Senior Leader for India. And she's the founder member for Association of Child Neurology, chairperson of Academy of Pediatric Neurology, and executive board member of Indian Epilepsy Society, and co-convener of Pediatric Epilepsy Subsection. Ma'am has won several awards, and she is, of course, not unknown to any of us. I would request ma'am to please say a few words on rare diseases in the context of SMA and the treatment. Thank you, ma'am.
Thanks. Thank you so much. Good evening, everyone. Can I start sharing my screen also simultaneously to save time, or you want me to speak?
Yes, ma'am. No, ma'am, you can share your screen.
Yeah. So actually, it is very important that we address the issue of rare diseases, because many of these patients have problems, and in many countries, it has been called, they are calling it as an orphan disease also, because people do not take much interest in that. And I in the recent meeting we had, there was, I had shared this, that I don't agree with this term calling orphan and even rare, because rare meaning you don't have to do, you don't have to give much effort and focus on that. So I am not agreeing with the thing where they're calling it rare and orphan, because these are important issues and challenges which we have. So we have to understand for these children. So SMA and DMD are very one of the commoner ones which we have, which most of the parents are facing. And I feel one thing, in most of these rare diseases have a genetic background, and when you have multiply effective siblings in one particular family with either DMD, SMA, or anything else, it is actually a failure of our medical fraternity. I think that once somebody has one of the conditions, then it is important that we do a proper genetic counseling and a prenatal diagnosis, so that children with this kind of things are not born like this. So that is something very important, and I wanted to say at the outset. And second thing I wanted to say at the outset is that for, there is a standard of care, especially for SMA and DMD, and because they are all both neuromuscular, but they are for others also. we actually are just focusing on the only the definitive one, the definitive treatment which is there and which are very prohibitively expensive. We have to obviously liaise with the government, and government has to understand of the we have to find out ways and means how, you know, there can be, you know, got whether the patents can be removed and whether Indian people industry can, you know, make them, manufacture them, you know, all those things are beyond ours, but they are the only potential things which come to our mind in a debate when you're talking about how to reduce the cost. So I mean, I just feel that we have to not forget when we are going after the, you know, and trying to get the definitive treatments which are there, we have to keep in mind that multidisciplinary care for all these rare diseases and, you know, should be done. So this is what I felt from the outset. And I think we should all understand that holistically the child should be seen and they should not be in silos. And obviously the parent support groups are doing a lot of advocacy and providing support, because very importantly, most of these conditions are because they're going to last a lifespan, so a life of the child. So the kind of trauma it is going causes to the parents is immense. So we have to treat not only the child, and I think we as clinicians, pediatric neurologists, geneticists, pediatricians, respiratory physicians, you know, the pulmonary medicine specialists, the nutritionists, the occupational therapists, physiotherapists, all of us have to come and think combined that we are not treating the child alone but the entire family. I think an humanistic approach is very, very important for us when we are dealing such families. uh, the uh, the topic given to me, should I start off with my topic also?
Yes, ma'am. Please do, ma'am.
Yeah. Okay, thank you. So after this brief preamble of what I felt impromptu about it, the topic given to me is SMA treatment and the experience. I have no known disclosures, just going to be very briefly mentioning the principles behind it. We need to pick them up early, identify early, because we do not have a newborn screening for SMA. So it is important for us to understand that. So that is why I wanted an introduction. What are the recent advances and holistic multidisciplinary management, which I mentioned, and the some little experience which we have had in the last 2.5-3 years. See, SMA basically initial description was in 1850s, and then SMN and SMN2 gene were discovered in 1992. And, you know, if you see with now the coming of FDA approved, the nusinersen is 2016, the gene therapy was approved in 2019. And now if you see in 2019, there were more than 400 papers. So there's a lot of interest in SMA and a lot of research going on in SMA. It is basically by, you know, they have hypotonia, they have looseness of the body limbs, it is symmetrical, it's more proximal, they may have some fasciculations of the tongue or tremors in the hands, and that is how you suspect the child is totally floppy, and, you know, you may have this kind of tremors in the tongue. Why I'm saying is important for us to understand that, you know, when once there's a problem, the video is not playing. I'll just stop sharing and again share. Yeah. So it is important for us. Why I wanted to show that was because we have to understand that the pediatricians have to pick them up early. So that is becomes very important. It's not playing. I don't know why. It's okay. I'll just okay, sorry. 1 second. This was playing till a minute back. Give me a second. I think there's some problem with the video. I'll just give me 1 second. I'll just close the window.
Sure, ma'am.
Otherwise, then you will not be able to see the patient videos as well, because the videos were playing very well till I started sharing. Once. Yeah, 1 second. Sorry. So basically, if you have you know, fasciculations are tremulous movements in the tongue, which is there, the tremors, and then if you put a outstretched hand, and there may be some small tremors which are polymini myoclonus, that will be seen in older children. So it is very important that we, you know, think about all this, because if we don't think about all this, then there will be a problem. And yeah, this is to ensure that if they are picked up early. Okay, I'm coming to the same slide. If it doesn't work, then it's all right. I have some technical glitch. I've presented these videos multiple times, so I don't know why it's problem. Okay, it works. So if it doesn't, it's working. Yeah. So these are the fasciculations in the tongue and this tremulous movement in the hands. This is important for us to understand and for the pediatricians pick up these patients early. But if you're having some weakness of the extraocular muscles, if there's arthrogryposis or CPK levels are more than 10 times normal, then we have to think there's something beyond. So the child can be picked up early as a floppy infant or a floppy child, and we do an MLPA. And if the SMN copy numbers are 0, then it is confirmed. If it is there 1 or 2, then we think about SMN direct targeted sequencing. And if there are no if the diagnosis is in doubt, then only we go to whole exome. Only idea was mentioning is you have to go MLPA first, and if there's a problem, then do SMN1 targeted sequencing, and only when the diagnosis is unclear, we go to the full exome. So basically, depending on the age of classification onset, you can classify them into SMA type 0, which is prenatal, and then type 1, which is less than 6 months, type 2 less than 18 months and onset, and type 3, which is more than 18 months onset. And 14 will if you have somebody in the adolescent, 13-14-year-old child or an adult onset, in those which may be having they may be having type 4 SMA. So you have to classify functionally as non-sitters, sitters or walkers, because that's important for your multidisciplinary care and management. And something very important is that you need to know the SMN2 copy numbers. Why I'm telling you here? Because all the new treatment advances are based on that. SMN2 copy numbers, like in SMA1, you have 2 copies, SMA2, you have 3 copies. Like this, it's important because it has relevance. I'll be talking about that why it is important subsequently. So what are the recent advances in management? There are 2 recent Cochrane reviews which are there, in which one was on SMA type 1, in which there were 2 trials in which and riluzole trials were taken. Riluzole was inconclusive, but there was definitive, they found moderate certainty evidence for the patients for the regarding mortality, requirement of ventilation, motor milestones in patients receiving nusinersen for SMA type 1. For SMA type 2 and 3, when you see the Cochrane, in which there were 10 placebo-controlled RCTs with 717 patients, nusinersen was found to have beneficial effect, and there was no beneficial effect of creatine, gabapentin, and hydroxyurea, butyrate, phenylbutyrate, valproate, etc., etc. So this was a thing. This is important. What we talked about SMN1 and SMN2, this is something important, is SMN2 is a backup gene, and we told you the copy numbers are important. What happens is, because of there is a difference between C to T, there's a difference in the SMN2 gene from SMN1. What happens is exon 7 gets deleted, exteriorized, so you get an unstable protein. What are we doing it now? What we are trying to do is, because we are trying to identify agents which prevents this exon 7 splicing, so that you get a more functional protein. Nusinersen, as I mentioned to you, was FDA approved in 2016, and it is an antisense oligonucleotide which helps doing this only by getting the SMN2 backup copy number to be increased by preventing this splicing. It has to be given intrathecally. Initially, there are 4 loading doses. First 3 loading doses are at the interval of 14 days, and the 4th is 30 days after the 3rd dose. And then you give maintenance 4 monthly the entire life. It is a single dose vial. It may cause thrombocytopenia, coagulation abnormalities, but in the patients we have seen, we have not found any significant adverse effects. So this is what we told, that because it is going to ASO is there, so it is going to ensure that the splicing of exon 7 doesn't take place and you produce a functional protein. There are trials which have been done. There were 2 trials which were done, which one was in the infantile onset SMA, and other was India, and the other was cherished late onset SMA. Both the trials had to be prematurely stopped. Because why were they terminated? Because there was significant motor response seen, so it was unethical to give the placebo. So then they both were stopped, and then the patients were followed up in open label studies, which is called SHINE. So there was another study, so you found in the infantile onset and the late onset. Then they did a study on pre-symptomatic SMA, and they have found that there was significant improvement in the pre-symptomatic ones. 96% were able to walk with assistance when they did the final, follow-up till June 2020. But they are going to continue the study till 8 years of age. And SHINE, as I mentioned to you, is an open-label extension of the infantile and late onset. Then they're also been trying to study the escalating doses of nusinersen in another trial. And they are also trying to see that some patients who have already been treated with Zolgensma, and whether if you give nusinersen, whether it will be beneficial. So this trial is also on. Now coming to Zolgensma, Zolgensma was approved on 27th May 2019 who are less than 2 years of age with SMA. Mind you, nusinersen has no age limit. It has been approved for all ages. This one has been approved for less than 2 years, and it is $2.125 million US single dose intravenous infusion, which is to be given, corresponds to around 16 crores. However, the total cost of treatment with nusinersen during a child's life is more expensive than the single dose of Zolgensma. And something important, produces a working SMN protein, does not change or become the part of the child's DNA. So for how long this is going to last, we do not know. That is why some studies are going on for understanding the longevity of the same. So it is entered through the vector, which is AAV9 is the thing. Through the AAV9, it is made to enter, and then it produces a functional protein comes inside. So there is a single dose infusion. Here you need to have to give to prime the patient with steroids 24 hours prior to giving the infusion, and you have to monitor by the liver functions, thrombocytes, the platelet counts, a troponin test that has to be done. And we have seen a lot of thrombocytopenia and raised OTPTs in our patients, which have required extension of the duration of steroids. So that is something very important. The basis of FDA approved bound basis of 2 studies, STRIVE and START, and in both the studies they had found significant clinical improvement. 91% of patients did not need breathing support at 18 months of age in one of the STRIVE studies, and in the START studies also 100% of the patients were finding that they did not need any ventilatory support. So there are many other trials which are going on along with this Zolgensma, and they also were trying, but the intrathecal infusion was initially tried, then it was stopped because they found that there were some side effects in the primates, but has been restarted now. Now they are also working on the pre-symptomatic infants, the same way like for nusinersen, so that in that also their results are still, interim results are promising. It is still going on. So that means if the early we pick, so that means you need probably a newborn screening. So that is to be sent. So multiple trials are going on. They are also trying to see the long-term follow-up studies, which are very encouraging as of now. And this long-term study, which I told you, which will be required, whether because it's the functional protein which is being produced with, is going to continue for lifelong or how. So this is a 15-year study which is ongoing. So coming to risdiplam, basically was FDA approved on 7th August 2020. It has to be given orally, and it was approved in European Commission last year in March 2021 and India in July 2021. And this is also in a similar way like nusinersen, it promotes the inclusion of exon 7 in the SMN2. That is why you need the SMN2 copy numbers when you're doing, and it does penetrate the blood-brain barrier, and it is given orally for lifelong. It is in an amber color bottle, and you need to be, they have to be the solution has to be made by the doctor and given to them, and they can have fever and diarrhea and rash, but we've not seen many patients with any of these problems. So this approval was based on studies for the symptomatic infants, young children, and the older children, and was found have good results. And it has also been shown to increase the expression of functional SMN protein in the blood. And the in the younger patients, this was a study. Rainbow fish is something important because in younger children from birth to 6 weeks they studied, and in this study they have found that they improve better milestones, and most of the infants who reached at 12 months had motor milestones similar to that of typically developing. So because it was a safe drug. So all the 4 trials which have been done, whether in small type 1A or type 2, 3, or in those pre-symptomatic, and that is how the pre-symptomatic one has led on 24th Jan 2022, risdiplam, which was initially approved by FDA for 2 months and above. Now they have given approval for less than 2 months of age as of 24th January 2022. Because earlier it was 2 months and above only. Cost implications are very important for us. Spinraza, which is intrathecal, and I told you 4 loading doses followed by maintenance doses 4 monthly lifelong, is 4.2 crores per year for the first year, and then 2.1 crores thereafter. Zolgensma one time 16 crores. You may say, if suppose that long-term study shows it wanes, if suppose the protein production is not going to remain, then you can't repeat, because when you have AAV9 titers are there, then you have antibodies and you can't give it again. So that is one thing important to be seen for this. And for risdiplam, it has to be given daily, lifelong, and for that it's 2.5 crores per annum is according to what it is there for the international, the rates which are there for international. And but the Roche is given some to the to the parent support group some support, and in that it is coming around 1.4 crores per annum for a 20 kg child. Other drugs are also on the horizon and a lot of studies are going on. There we have problems in approach getting one drug, but there are people, the studies are being done to whether you can have combinations on. So just we have to know that the trials are on. We have had humanitarian access programs in India. The Spinrazabad by Direct Relief, which is an NGO from US, since July 2019 they came, and we had put 145 applications. 13 patients were selected, out of which one SMA type 1 died before the medicine was shipped, and 12 patients have been under follow-up from December 2019. And in last year, February, March, we had a call again, and then we had 38 patients got selected, but 3 patients had applied from 2 different centers, unfortunately. So then we have 35 of them under now follow-up. So this is for SMA type 1, 2, and type 1, 2, and 3 all. Then the that is only for India, the Spinraza. But there is a global managed access program by Novartis, in which every 2 weekly you have a lottery for these patients for SMA. For any, the limit is 2 years. Under 2 years, they are doing it. So I'll be just mentioning about our patients. And for Roche had come up with this compassionate program in 14 January 2020, but now they have discontinued it ever since it was launched last year. But they are giving the drugs to the patients who have been selected. But I want you to know that there is a multidisciplinary arrangement which is important, looking at the growth and nutrition, pulmonary, cardiac, and other systemic evaluation, psychological support, and physiotherapy, occupational therapy, and musculoskeletal system. Everything has to be seen, and depending on the functional classifications of non-sitters, sitters, and walkers, and there are guidelines which are there, and one has to just remember that palliative versus proactive approach has to be seen. Palliative care is when is end of life care, so we have to know when, until when are we going to be aggressive, until when are we going to start on palliation. Just remember that we have to have a humanistic view of life towards every of these children, because all of them, all lives are precious, and we have to have it due respect till the end. But we need to have all these evaluations, and all protocols have to be followed, not only the specific one. Lastly, just mentioning about the experience, we did the trial. I had done a trial on gabapentin and SMA, and that was a negative study. It was long back. Then about 15 years back, I did this study on valproate and carnitine SMA RCT. Again, this was negative and has been conclusively by the, what the Cochrane was there. So as I mentioned to you about the patients, nusinersen, I've given you the numbers, just giving you one video from all the 3 categories. I've already given you numbers that 12 patients have been following up for since 2019 December, and 435 new patients have been started in the last few months. So this was our first patient, and when the child came, she was creeping on the stairs. And when after the maintenance first, that is going to be maintenance first is going to be from the onset, you give the first listing for loading, and after that 4 months later, so around 8 months later, you found that she could stand from herself from sitting to erect position and could maintain the posture. This was there at the first maintenance phase, and this was same thing I've showed in pictures. And then afterwards, the child has now started able to walk with the walker, and is started walking with the walker. Another child was there having started sitting, only transient sitting with support was there, but after till the maintenance one could sit with raising the arms to the ear levels. Initially could not, he was just having partial support. One sec. Regarding the gene therapy, we have given to 8 patients till now. Another patient will be getting next week. So this is the pre-therapy of the first child done on 29th May 2020. And now at 21 months, the child is able to have independent sitting and can stand with gaiters. Regarding this plan, we have had, 7 plus 9 patients who are on RISD plan. And I'll just show you about one. A child could bear weight on 4 arms. And now after 5 months, then the child could bear weight on extended arms, extended hands. So the independent sitting for more than 30 minutes came up in at 5 months. And now at 13 months can independently sits and in place independently with toys. And now, we are coming with another trial. Novartis has come up with AIMS as a site in which you're giving a single dose gene therapy, which is going to be given intrathecally from the age group of 2 years to 18 years. So they are going to be expanding to that. points to remember is when to suspect, early diagnosis, near therapeutic options, yes, but a multidisciplinary care. Please think about genetic counseling and prenatal diagnosis. You cannot have multiple patients affected in one family. But most importantly, remember the multidisciplinary approach. Meanwhile, when we are trying to get the specific definitive options. And we need to empower our parents with also patient information material we have for all the neurological conditions. 45 of them are there. And we have DMD, SMA, all of them are there. So I'm really grateful to all the families and the children who have already given opportunity to treat them. Thank you so much. That was just a rapid, brief overview of what are the things available and what experience we have had.
Thank you so much, ma'am. It's so encouraging to see the videos of the children improving. It's something that we have been seeing only the bad side of SMA with babies dying on us. And it's so encouraging and so nice to see that children are actually doing well. A wonderful follow-up. Thank you so much, ma'am, for sharing. We will move on to the keynote lectures now for the evening. We have 2 lectures in tandem. But first, I would like to invite on the podium Dr. Neerja Gupta. Just if you could give me 2 minutes. Yeah. Dr. Neerja Gupta is associated with Division of Genetics, Department of Pediatrics, AIIMS, New Delhi. And she will be speaking on the recent advances on DMD and also a bit on the DMD therapies. Ma'am, we welcome you today in this forum, and over to you, ma'am.
Thank you. Can I share my screen?
Yes, ma'am, please.
Is my screen visible?
Yes, ma'am. You have to go to the full screen mode, ma'am. Yes, ma'am. Perfect.
Is that okay?
Yes, ma'am.
So good evening. At the outset, I would like to thank the organizers for giving me the opportunity to speak on recent advances in the treatment of Duchenne muscular dystrophy. So I would like to say that we work with Pediatric Neurology Division to manage these children. These are primarily managed by them. And being a genetic disorders, we are involved in their diagnosis and then prenatal diagnosis and prevention. So in this talk, I shall be mainly touching upon the recent advances which are available for these patients and the drugs, how do they act. And presently, I do not have any first-hand experience for dealing with these patients. So we all know that DMD is a severe progressive genetic disorder, which is X-linked recessive in nature, and 1 in 5,000, it affects 1 in 5,000 newborn boys. So mutations in DMD gene results in lack of functional dystrophin protein, which further results in gradual loss of muscle tissue and function, which leads to wheelchair dependency by 12 years, and then followed by assisted ventilation and premature death in Duchenne muscular dystrophy patients. So before going into the therapy, it is very important to understand the genetics, because most of the therapeutic approaches are using genetics as a baseline for, so it is important to understand. So it is a very big gene. About 2.4 MB full length DMD gene is there, which comprises of 79 exons. And there are 4 major domains of this full length dystrophin protein, which is important to understand because there are several approaches which include this the small length dystrophin protein into the therapeutic approaches. So it is important to understand the mutations also, because majority of them are 60 to 70% of them are deletions and 5 to 15% are duplications, which are more commonly seen in BMD as compared to DMD. And in about 1/3 of the patient, there are point mutations, and of these point mutations, the nonsense mutations are relatively more common in DMD patients, thereby explaining the severe phenotype. So there are 2 hotspot regions, that is 44 to 53 and 2 to 20. So these have been in research, and most of the research is being targeted on these exons because these are more widely available, and the distribution is same in every ethnicity. So So 1/3 of these mutations are de novo in nature, meaning thereby that it will not be inherited further, but majority of them have X-linked inheritance in that particular family. So there is one basic rule which applies in DMD, that is the reading frame rule, which means that if there is alteration of reading frame, so which is known as out of frame deletions or duplication, it will result in no generation of functional protein. So there will be no functional protein for the out of frame deletions. Whereas if the reading frame is not altered, then it will result in frame deletions, and which means that the reading frame is maintained. Here the reading frame is disrupted. So when the reading frame is maintained, then it results in partially functional protein. So the therapeutic approaches have used in changing this out of frame deletions into the in frame deletions, and we will see how. So as of now, the standard of care is giving corticosteroids because it improves the muscle function and delays the loss of ambulation. Nutritional management, GI tube feeding, treatment of cardiomyopathy if it is there, scoliosis, physiotherapy, and all sort of supportive management. The various therapeutic approaches that have been used, and first most important therapeutic approaches to target the primary defect to restore the functional expression of the dystrophin. And this is possible by means of gene therapies, cellular therapies, or protein replacement therapies. These gene therapies include exon skipping, stop codon read-through, gene addition, or gene editing therapy. Whereas the second therapeutic approach is targeting towards the downstream secondary pathological changes, which results in improvement in muscle quality. And this is achieved by using therapeutic strategies targeting the fibrosis, which is a very much advanced in these patients in an advanced stage, anti-inflammatory agents, and reduction of muscle damage by utilizing calcium dysregulation, oxidative stress, targeting muscle ischemia, muscle atrophy, and maintaining bone homeostasis. So this complex diagram, it just shows that the two therapeutic approaches, one of them is targeting on the gene and the functional protein, the protein replacement in the cellular therapies, and is very much in use. And the second is the downstream secondary effects targeting the fibrosis, inflammation, improving muscle function, and the bone homeostasis. So I shall be focusing mainly on this part, that is the related to genetic therapies. However, there are certain challenges that it is not very straightforward that even if we target the dystrophin related therapies, restoration of dystrophin expression, it does slow down the progression of DMD, but it do not restore the degenerated muscles. So which means that if we initiate early, then it will be better. But if the muscle is already degenerated, then it may not be that much effective. And one important principle and point which is important to remember is that it is difficult to target all the muscles. Muscles are very highly abundant in our body. It constitutes about 30 to 40% of the body mass, and there are more than 500 different skeletal muscles. And moreover, these muscle fibers are surrounded by layers of connective tissue, which hinders the expression of vectors such as stem cells or viral particles. So these are the few challenges. So going on to the exon skipping therapy, which is very much widely available. In this therapy, we use pre-designed antisense oligonucleotides, which means they are short 15 to 32 nucleotides, single-stranded nucleic acid sequences, which hybridize to the complementary RNA segment. And it's a very crucial step is involved in this, that these oligonucleotides should bind to the specific exons and induce the targeted splicing in the pre-mRNA. This is the most crucial step. And then once these AONs, they target the specific exon, they target at the donor or the acceptor splice site or the putative exonic splice enhancer sites, which converts the out-of-frame deletion into the in-frame deletion, thereby converting the DMD phenotype into a less severe BMD phenotype. So this is how it happens. In healthy children, you have normal exons, 43 to 56. There is mature mRNA. There is splicing happening. There is mature mRNA, and you have full-length dystrophin protein. Whereas in patients with DMD, in this patient, there was a deletion between 45 to 52 exon. So, so you can see that there is no lock and key mechanism. Here there is a lock and key mechanism that every lock is fitting, every key is fitting into one lock. But this mechanism is lost here, so it becomes an out of frame deletion, and there is no dystrophin protein. However, when we use exon skipping using Wilto-Larsen, which targets the exon 53, and where we use antisense oligonucleotides, when this binds to this exon 53, which and this exon is spliced out, which results in again establishing the lock and key mechanism, and there the 44 joins with 54, and this out of frame deletion is turned into in frame deletion, and which results in truncated but functional dystrophin protein. Similarly, there is exon 51 deletion. There will not be any dystrophin protein because of the loss of this mechanism. But when we target this with antisense oligonucleotide, this 52 will be spliced out, and this is established, and there is a functional dystrophin protein. So these are the three drugs which are available and FDA approved also since 2016, and they target 51. Target exon is 51 for Eteplirsen, Golo-Nederson, and Wilto-Larsen. They target the 53 exon. The dose is weekly for all of them, and you can see that the cost is exorbitant for this. We should remember that these three medicines, they did not cover all types of deletion. It is just 20% of the deletion which are covered by this particular therapy. The effect is seen by using 6-minute walk test and the increase in dystrophin protein expression in the muscles in the various studies. However, long-term safety and efficacy is yet to be established. So this is a very nice chart which is available on Cure Duchenne website, which suggests that which are the deletions which are amenable to exon 51 skipping and exon 53 skipping. So whenever a patient turns into the clinic, we look into this type of chart and tell them about the availability of treatment and the other consequences depending upon the severity of the disease in that particular patient. So as we know that every therapy has challenges also, so same is true for exon skipping. So there have been some attempts to improve the antisense oligonucleotide efficiency and uptake by the skeletal muscles and the heart by using certain chemical modification and the peptide conjugates or arginine or muscle homing conjugates. There has been attempt towards using multi-exon skipping, which includes 45 to 55 exon skipping together. So this is also one of the things which is happening. There has been attempt towards the exon 2 skipping due to exon 2 duplications. And combination of gene therapy and exon skipping is also being tested. The second important part is stop codon read-through. As we know that nonsense mutation, they constitute about 13% of these patients. So whenever there is nonsense, so this is a normal protein, which functional protein, which is being formed when there is normal translation. But because of this nonsense mutation, there is premature stop codon generation, which produces the dysfunctional dystrophin protein. So there are certain molecules like gentamicin, etaluran, which combines with this premature stop codon and stimulate the stop codon read-through and thereby facilitates the functional generation of functional protein. The gentamicin has its side effect, renal as well as ototoxicity is there, so it is not being used. However, etaluran is approved by EMA and not by FDA because of the limited evidence. Some of the trials are underway, and probably AIMS is also one part for some of the trials. So the third is gene addition, which actually appears very fascinating, because if you replace the dysfunctional gene with the normal gene, it appears that it will reconstitute, it will help in normalization of the function. However, as we know that the gene is, this DMD gene is very high. So the virus, the adeno-associated virus, which infects skeletal muscle with high efficiency, it has limited transgene capacity so it cannot accommodate this full-length dystrophin mRNA. So therefore, microdystrophin genes are used, which are partially functional. So this diagram shows that this is the normal dystrophin protein, but in the microdystrophin, you just have the most crucial part of the dystrophin proteins. So this is microdystrophin, which is possible to integrate into the adeno-associated virus, and especially these serotypes are very much important because they have striatal muscle tropism. So this is one molecule which is being tested, and this was recently presented in last year conference, wherein 19 patients are receiving this mode of therapy, and the results are promising. And there are certain more research going on microdystrophin transgene in other countries. So the fourth is gene editing, which uses CRISPR-Cas9 system, which is an adaptive immune system in the bacteria against invading bacteriophages. It is a powerful tool for DNA editing, and here one inducts the special double-stranded DNA breaks by CRISPR-Cas9 in the genome, and this is followed by activation of DNA repair system to correct this missense mutations by homology-directed repair-based germline editing or non-homologous end-joining based postnatal editing. So you are cutting through a scissors, and in simple words, you are cutting through the scissor and then stitching it by using DNA repair mechanism. So here also you need AAVs for the in vivo delivery system, and it has a potential to bring clinical benefits to about 2/3 of the patients. However, there are challenges because of the excessive immune responses due to exogenous AAVs and the off-targets effect of the induction of the double-stranded DNA break. So this is how it looks like. So normally the transcription is followed by splicing, and then if there is a deletion, there will be outframe mutation and the protein is truncated. But if we use this gene editing, you cut it, and then this exon 53 is spliced out, and then exon 51 combines with 54, making the lock and key mechanism perfect, and the reading frame is restored. So the gene editing is using some enzymes to cut and then repair. Then we have stem cell transplantation, which means that transplanting cells which contains a functional copy of DMD for muscle repair after the transplantation. Different types of stem cells have been used, like satellite cells or bone marrow derived cells, pericyte cells, mesenchymal stem cells. However, there was no functional improvement in various studies using these types of stem cells. Engraftment of human-induced pluripotent stem cells appears to be promising, and some work has already been done in AIMS also, though in vitro. So there are challenges with cell survival and migration. There are challenges with suboptimal delivery and because the muscle is an abundant tissue, so there are challenges in meeting the targets everywhere in the body. Then the eutrophin upregulation is one of the other strategy which appears to be promising, because eutrophin is a structural and the functional autosomal paralog of dystrophin. So in dystrophin mice, the upregulated expression shows that it can prevent the development of muscular dystrophy. However, when different types of upregulation, different types of molecules were used for the upregulation of eutrophin level, the results were not very promising. So, and other disadvantage is that the eutrophin cannot prevent the functional ischemia during muscle contraction, which happens in these patients, and it cannot bind to the microtubules, which is possible with dystrophin. So it appears that the combination of eutrophin-based therapies as well as the dystrophin-targeted treatments for DMD will be more beneficial as compared to the using eutrophin upregulation alone. So this is just a table which shows different type of strategy, and we can see that the exon skipping therapies, the 3 medicines are FDA approved, and we have etaluran also, which is approved by EMA. So there are many more trials which are ongoing, and it is heartening to know that some of the drugs are used as oral in oral mode also, because it is not always possible to have the weekly injections, and the family has to make a lot of adjustments. So key points are that we have we are living in an exciting time, and we have approved therapies like etaluran and eteplirsen, which addresses the primary defect, though it tailors to only specific mutations. And there are promising results using microdystrophins. More efforts are needed to improve the applicability and achieving the widespread delivery of these several molecules and the gene addition therapies. The combination of therapies addressing both the primary defects and the secondary consequences appears to be beneficial. Thank you.
Thank you so much, ma'am, for such a wonderful lecture and such a comprehensive view of all the therapies which are available at this moment to us. I hope that we develop something very fast in India too, so that we can also negotiate with the cost which is associated with all of this. With this, we move on to our next keynote lecture, and I would be introducing Dr. Sunita, ma'am. Just a minute, sorry. Just a minute. I would be introducing Dr. Sunita, ma'am, for this particular talk. Please excuse me, I am having a certain difficulty sharing the screen. So sorry, just give me 2 minutes. Sunita ma'am is associated with Institute of Medical Genetics and Genomics, Sri Gangaram Hospital, and she obviously, we all know her. She has more than 100 publications to her name, and she's the executive member in Indian Society for Newborn Errors of Metabolism, corresponding member for Indian Council, member of SSIEM, and she's the founder member for SFM. She's the editorial board member for Indian Pediatrics Journal of Fetal Medicine. And ma'am would be speaking today on LSDs and the treatment modalities. I welcome ma'am for the lecture. Ma'am, over to you.
Good evening, everyone. Thank you, Dipanjana, for such a kind introduction. I really want to thank the Rare Disease India Foundation and the organizers for giving me this opportunity. I will be very, very brief because I know I should not take too much of time. So I prepared a very brief presentation on my topic. I want to start my screen now. Dipanjana, can you see the screen?
Yes, ma'am.
Okay. Yeah. So the topic provided to me was gene therapy in lysosomal storage disorders. So we all know about lysosomes, so I should not be elaborating on too much. Just a little 2 lines that it is really lysosomes are really key cellular hub for the macromolecular catabolism in the body. It takes care of all the unutilized and unwanted material in the cell, and it helps to degrade them by use of many enzymes within itself, which is a very acidic environment. So there are lots of cellular processes going on, including catabolism, recycling, and signaling. So defects in these metabolic pathways, they impair the function of these molecules, and thus basically leading to storage of the unwanted material or impairment of the transport of these molecules, and thus causing cellular damage. We all know that it is a large group of genetic conditions with over 70 disorders till now, with a combined incidence of prevalence of 1 in 5,000. So it can be divided into many, many categories, among the 70 odd disorders. These are the groups, including the sphingolipidosis, where we have the Fabry, Gaucher, the gangliosidosis, Krabbe, MLD, Niemann-Pick, the lipid storage, then mucopolysaccharidosis, mannosidosis, then other like glycogen storage and NCL, etc. So there are already some treatments that are being offered to patients with lysosomal storage disorders, including the enzyme replacement therapy. But here I am going to talk about gene therapy. So basically, what we mean by gene therapy is we would really like to cure the patient. So gene therapy is a replacement or correction of a genetic defect to cure a disease. So the recently gone by teens of this century have been the most successful as far as the gene therapy is concerned, because we have now seen the actual realization of the potential of gene therapies. And we have heard Dr. Shifali Gulati talk about the SMA gene therapy, and also a few other gene-based therapies such as the CRISPR and the RNA-based therapy by Dr. Mirja Gupta. So lysosomal storage disorders, as I said, there are many disorders, and gene therapy has been, it is under research and it has been tried in animal experiments in many of these disorders, including MPS, the MLD, Krabbe, NCL, Pompe, gangliosidosis, etc. When we say gene therapy, basically it is the introduction of the gene, the corrected gene. Now, whether it can be, it can have two strategies. One could either put the gene inside the body as it is, which is called in vivo, or it could be done ex vivo, which means we take out some cells of the body. The most common strategy used is that of the hematopoietic stem cells. Then we introduce the gene via the vector and then reintroduce the same into the body. So this is outside the body or ex vivo. Both the strategies are being tried and with equal success. So mucopolysaccharidosis is a huge group. In our own practice, we see about amongst the LSTs, this forms the largest chunk with about a third of patients presenting with this. Gene therapy should be a one-time permanent therapy and repairing the cause of this enzyme deficiency. So a lot of preclinical studies for gene therapy for MPS have been developed in the past 3 decades. Currently, there are clinical trials for gene therapy for some of the MPS, and these are basically listed in this table, which I've taken from the article in MGM from 2018. So there, as you can see, there are multitude of gene therapeutic trials going on in many disorders, such as the MPS 1, 2, 3A, 3B, and MPS 6. The modes of gene therapy are basically using a vector, and they are usually the AAV virus. And inside the body, it reaches either using intravenous route or intracerebral route or intercisternal route or intraventricular route as well. So all these routes are being tried, and they are in various phases of the experiments, like phase 1, phase 2. But really, there is no such trial which has really come up as a successful human trial as of now in MPS. So just anecdotes of 1 or 2 disorders, MLD, there have been a lot of enthusiasm in the mid-teens about MLD becoming successful genetic therapies. So like this paper, it says that lentiviral hematopoietic stem cell gene therapy benefits metachromatic leukodystrophy. This group gave gene therapy in 3 individuals with metachromatic leukodystrophy, and they produced successful results. But subsequent to that, it has not been taken forward. I mean, there have been good experiments in animals, but not yet in the human being. So we are not there yet. Similarly, and a very recent just news item showed that CO Gene Therapies reports positive interim data on gene therapy trial. So we have a few ongoing therapeutic trials in GM1, where only early results show that there was some promising. So here this group I think in Portugal showed a phase 1-2 study using the AAV virus, and it showed some benefit in patients. Now, this is the latest news which came just in this February, and it says that this is the first gene therapy for Tay-Sachs disease, which was successful when given in 2 children of Tay-Sachs. So Tay-Sachs is a very common condition, especially in the Ashkenazi Jewish population, but it is also common in our country. So these are some genetic therapies that are coming up, and we should be really hopeful. So basically, my topic was where we are. So gene therapy gives us real hope. So the hope is not just a hype, it is a real hope for treatment in the near future, I would say. But if we consider the status for gene therapy today, then of course we are not there yet. We have to wait and see. We have to have a watchful eye. We have to participate in all the clinical trials that are happening. That's what we do at our center. We keep reaching out to the researchers and try to get our patients into the trials, and let's hope for the best in the future. So, while we are waiting for the gene therapy to happen, what we do today is, of course, manage our children, our patients with using a multidisciplinary approach, and with all these one or all the parts of the puzzle connected, and everybody works together to manage these children. So this is really the key in treatment for all the lysosomal storage disorder, is that we have to all come together for the cause of these children who have this rare disease. And that's how I end my talk. So I wish you all very happy Rare Disease Day, which happens to be tomorrow. Thank you very much.
Thank you so much, ma'am, again for such a comprehensive view and showing us the path of where we are for the gene therapy at rare diseases. While we were speaking about management in all of these previous cases, it becomes also very important to reduce the disease burden. As Dr. Shefali Gulati actually said in the first lecture, that there should be no way that a single family has two affected children, or a single family has two affected members. That is something which will be on us. And to bring forward and put light on that topic, we have Dr. Divya Agarwal with us. And she will be talking on this aspect. Divya ma'am is affiliated with Apollo Indraprastha Hospital, and she again has a lot of publications to her name. She was formerly associated with as a consultant with Gangaram Hospital in New Delhi. And she has her area of expertise include neurodevelopment, neuromuscular disorders, skeletal dysplasia, metabolic disorders, dysmorphology, malformation syndromes, IUGR, and she is the member of different academy like Indian Academy of Pediatrics, Indian Academy of Medical Genetics, Society of Fetal Medicine, and Indian Society of Inborn Errors of Metabolism. We would request Dr. Divya Agarwal, ma'am, to please share her experience on the families, and she will be talking on the aspect of genetic disorders, prevention of genetic recurrence of these genetic disorders.
Thank you very much, Deepanjana, for the introduction. I thank all the organizers for inviting me for this National Rare Disease Symposium. The topic that is given to me is prevention of recurrence of genetic disorders. And we know that most of the rare disorders are genetic in origin, and most of the genetic disorders are rare, excepting a few like Down syndrome. So basically, genetic disorders and rare disorders do go hand in hand, and they do have a risk of recurrence, and hence prevention of these genetic disorders is of paramount importance. And as Dr. Gulati said, that, you know, if we have a recurrence, if we have a family with more than one child with a genetic disorder or with a rare disorder, then it is very painful, and it is very hurtful, and it is actually a failure of the healthcare. So knowing about prevention is extremely, extremely important for the families who have children with rare disorders, for the lay persons, as well as for the healthcare professionals. So any prevention could be a primary prevention, secondary prevention, or a tertiary prevention. So when we're talking about prevention of any disease, we could prevent the disease at any of the stages. Primary prevention essentially means avoidance or prevention of the risk factors which lead to that disease or which lead to that condition. In our case, in rare disorders or in genetic disorders, primary prevention would probably mean something like a pre-implantation genetic test, or to use a donor germ cell when we know that, one of the partner or both the partners are carriers of genetic mutations. Secondary prevention means early detection of the disorder and intervention in order to decrease the manifestations, or in order to avoid the manifestations totally of a disease or of a condition. And tertiary prevention means treatment and prevention of the complications of a disorder. So with respect to the rare disorders, when we talk about the primary prevention, it means intervening before the rare disorder occurs. And this is actually the most, the most effective strategy of prevention for every disease or for every condition, but it's not always the most feasible option. Like folic acid supplementation for avoidance of neural tube birth defects is the most common primary prevention that we would know of. The other modes of primary prevention for rare disorders or genetic disorders is proper genetic counseling. It could involve giving information about the genetic disorders to layman, giving information to couples before they are planning a pregnancy, getting them tested for any carrier for genetic mutations, which means a preconception carrier screen, or doing an in vitro fertilization or using artificial reproductive modes, and doing a pre-implantation genetic screening of the embryos. Now, this approach, after the preconception carrier screening or the pre-implantation genetic screening, what do we do then? Avoidance, do we avoid the pregnancy? Do we avoid a child with monogenic disorder, by not marrying a carrier, or by totally avoiding a pregnancy where both the partners are carriers of recessive disorder, or by a woman who is a carrier of X-linked disorders? Because primary prevention essentially means totally avoiding the risk factor, or using a donor germ cell in the recessive disorders. And these options may not be feasible, may not be practical in the day-to-day practice, or because of socio-cultural reasons, they may not be acceptable to a lot of families who already have a child with rare disorder, but they do want another child, another normal child. So I would like to emphasize the role of primary prevention by just this very short case example. Like this was a 36-year-old female who presented with family history of her nephews having intellectual disability. So this girl, this lady, she was avoiding pregnancy, and she was so scared to get pregnant because there was a family history of intellectual disability and behavioral disorders in two of the children in her family. And she came to us with the concern that, is there any way that, this could be prevented in my child? And this family was from outside. We didn't have the proband with us, but we counseled them and counseled the couple, and we told them that we need to know what is the diagnosis, we need to examine the children, or someone needs to see the child and reach to a definitive diagnosis for us to be able to help you prevent the recurrence of this condition in your children. So this basically, they were, the children were living outside, and they were assessed by a team of neurologists and geneticists outside the country. And they ordered a microarray on one of them, which picked up an X chromosome linked deletion. It is, there was a deletion of a part of an X chromosome, which carried certain important genes, which led to the intellectual disability or autism in these children. And since this deletion was linked to the X chromosome, there was a high chance that this lady could also be carrying the deletion. And hence we tested this girl, this 36-year-old woman, and she was also found to be carrying this particular copy number variation. Now, prenatal test, on the basis of this deletion, we told her that, you could get pregnant. There is a 25% risk of recurrence in your child. But we could do a prenatal test during pregnancy at 11 weeks in order to prevent the birth of an affected child. However, her religious cultural background was such that it did not permit her for termination of the pregnancy, and hence the option of in vitro fertilization with pre-implantation genetic testing or an in vitro fertilization with an ovum donor was provided. So now the key thing here is that awareness of the family members, the cognizance of the family that they could be at risk of having a rare disorder, of having the genetic disorder, which is recognize that particular risk and reach out to the specialist, to the relevant specialist, is extremely, extremely important. Also important is the awareness of the doctors to order the correct tests, as well as to refer to the relevant specialist. And that is what I also wanted to highlight, which is actually the key for prevention of these genetic disorders. Now, coming on to secondary prevention, which means actually to detect early any genetic disorder and intervene to avoid the manifestations, which means avoiding the birth of a child with a rare disorder by screening for these genetic conditions during pregnancy, or early diagnosis of these rare disorders by strategies like newborn screening, where the newborns are screened for these common genetic disorders, as well as early diagnosis of the genetic disorders and intervention and treatment in whichever way that is possible to decrease the manifestations, to avoid the manifestations, or to decrease the manifestations. And these secondary prevention measures would include things like prenatal screening, which screen for the chromosomal abnormalities, as well as for malformations, birth defects in the child. Prenatal testing by amniocentesis chorionic villus sampling, in which the fetal cells can be taken and DNA can be extracted, fetal DNA can be extracted and tested for the various genetic mutations. Newborn screening, particularly for the metabolic disorders. And again, I would like to quickly present two case representations to highlight the importance of secondary prevention. This was a 3-month-old firstborn boy. These were non-consanguineous parents, and he was noted to have short upper and lower extremities and some facial dysmorphism. And actually, antenatal ultrasound at 32 weeks had revealed short femur, but sometimes screening tests like ultrasound, they become very tricky and ambiguous. For example, in this family, in the previous pregnancy, at 5 months, the fetal ultrasound had shown short long bones, after which the pregnancy was terminated because of suspicion of a birth defect. However, during this pregnancy, even after careful ultrasounds, the first weeks, and hence the need for a definitive diagnosis in the family is highlighted now for the prevention next time, and not just screening tests like ultrasound for prevention during the you can see the flat facial features, and there was bilateral upper and lower limbs rhizomelic shortening, both leg bones were bent, there was some organomegaly, and there were plenty of skeletal abnormalities, the characteristic feature being the areas of stippling that were seen in the epiphyseal regions. There was a lot of metaphyseal abnormalities also, and then on the basis of certain biochemical tests, the clinical differentials were made. However, the most likely diagnosis was a storage disorder called mucolipidosis, eye-cell disease, in which this is a lysosomal storage disorder, in which the enzymes, multiple lysosomal enzymes, are increased in the plasma because of a defect in internalization of these enzymes in the lysosomes, which was found in this child, and it was confirmed by the genetic testing, which revealed homozygous deletion in the gene. And this is how a prenatal test was offered in the next pregnancy then for prevention. So this is a secondary prevention based on solid genetic testing, and a conclusive prevention can then be done in the next pregnancy. Another case here, a 1.5-month-old child presenting with lethargy, decreased activity, respiratory distress, normal term-born, no neonatal complications, otherwise first-born child. And on examination, the child was really unstable. IV cannula was put and the child was tried to be stabilized. Along with all the samples were taken, the blood samples were taken, the urine samples were taken, and on the preliminary testing, it was all suggestive of a metabolic disorder, although these changes could occur in a sepsis as well, in an infection as well. But you could see that, CBC was normal, CRP was normal. There was no evidence, that was very, very discrete of infection, and it pointed, the biochemical tests pointed to a metabolic disorder. And hence it is very important to then order the relevant metabolic tests, which then revealed something suggestive of the most common organic acidemia. However, the mutation found in this case was in a cobalamin C gene, which is a gene responsible for metabolism of cobalamin, which is a cofactor for this particular enzyme, methyl malonic acid, which results in the decreased activity of the enzyme and results in methyl malonic acidemia. Now, the importance of this diagnosis is that usually cobalamin C disorders would present later. They would not present in such early life. They would present with developmental cognitive decline, and hence, although vitamin B12, and if diagnosed very early and intervention is done very early, a lot of complications of neurological complications can be avoided. So here, the management was started, the acute metabolic derangements were corrected, and the definitive management was started, and the long-term plan has to be given to the patient. And when, along with a proper diet and along with a long-term management, these children will do very, very much better than they would otherwise do. So this was also an example of secondary prevention, how early diagnosis and interventions, even if definitive treatment is available, but early interventions can really improve the outcome of these rare disorders. And now coming to the last part, which is the tertiary prevention, wherein most of our disorders and most of our rare disorder children will fall, where we have to provide them with adequate care and rehabilitation in order to prevent complications in them. And it includes early stimulation, behavioral interventions, provision of hearing aids, and above all, emotional and psychological support to the affected individuals. Here again, I would like to just highlight tertiary prevention by these two small cases. Now, this was a family, two brothers, 14 and 16 years of age, with acute, excruciating and unbearable episodes of pain in the hands and feet, and they had been going from pillar to post, and in search of a diagnosis and in search of a relief of their symptoms. However, they were then seen to have angiokeratomas, and there was history of febrile episodes, and diagnosis of suspicion of Fabry disease, or which is a lysosomal storage disorder, was made. The diagnosis was confirmed by enzyme analysis. This patient, these two brothers, were started on enzyme replacement therapy, and the pain episodes became almost nil. Now, this is a disorder which which could have been under the secondary prevention, wherein you do an early diagnosis, you intervene, and you just prevent most of the manifestations. However, here there were a lot of manifestations already, but in order to prevent the complications, the enzyme replacement therapy fortunately was available, which could prevent the various renal, cardiac, neurological, stroke-like complications for these two brothers. Another case highlighting the importance of tertiary prevention: a 5.5-year-old boy presenting with short stature and hearing loss, and had cleft palate, because of which he had recurrent aspirations during the neonatal period. Very, very turbulent neonatal course. He was in the NICU for about 4 months. Bilateral club feet, small limbs, particularly the hands and fingers. A diagnosis of dystrophic dysplasia was made and was confirmed. He was in the NICU for 2 months. Now, the management that was done for this child, the gastrostomy was kept till 9 months of age, after which the child was operated for cleft palate. For the CTEV, tenotomies were done, regular physiotherapies, hearing loss was detected, and then speech therapy started, hearing aids were used. And the result was that this child was doing very, very well at 5.5 years. He was studying neurologically absolutely normal, could walk with calipers, his understanding was normal, he could speak in sentences. So this is the tertiary prevention and management that we're looking at. And most of the skeletal dysplasias with normal intellect, we could achieve this. And there are so many people out there who have made it, who've actually had a very, very good quality of life by preventing the complications, by an adequate management. This is Little People of America is a very, very active skeletal dysplasia group, and this Roloff family is probably one of the more famous families. And I wanted to show this because I wanted to end on a positive note here, that in spite of all the nuances and all the complications that are associated with rare disorders, a lot of children, a lot of people with these diseases, with primary, secondary, as well as tertiary prevention, can have a good quality of life. And whichever stage of prevention we are looking at, now rare diseases and public health or preventive health is not an oxymoron anymore. It's not, they're going hand in hand with various organizations, with various patient support groups, with now at least a start from the government in the form of national policy. Rare diseases are becoming part of public health. So thank you very much.
Thank you so much, ma'am. And it's such a big hope for us also to understand that not only we can prevent, but even in people, if the PAG groups come along, there's actually a lot that can be done. And it's very important for all the PAG groups and support groups to also come along when we actually speak of preventive therapies or prevention of recurrences as well. With that, we come to the last lecture of the session, and I would like to invite Dr. Lieutenant Colonel Aradhana Trivedi to this session. Lieutenant Colonel Dr. Aradhana Trivedi is Assistant Professor, Army Hospital Research and Referral Center, Delhi. She is the alumni of prestigious Armed Forces Medical College, Pune. Being the first geneticist of Armed Forces Medical Services, she is vested with the responsibility of setting up the first nodal center for genetic disorders in Indian Armed Forces. Her area of interest include lysosomal storage disorder, dysmorphology, inborn errors of metabolism, neuromuscular disorders, and neurodegenerative disorders. Welcome, ma'am. Ma'am would be speaking today on management of LSDs and management of MPS rather, and the challenges which are faced in the management. Over to you, ma'am.
Thank you so much, Dr. Dipanjana, for that kind introduction. So quickly, I'll share, I think we are running short of time. So I'll just share my screen. Is it visible? I'll just put it on slideshow. It's okay?
No,
Can we see?
yes, ma'am. You have to come on full screen, ma'am. It's still not full
I'm
screen.
on full screen.
Okay, ma'am. Ma'am, if you can just sort of, stop your share screen and share your whole computer screen, then probably it will come, because for us it is just it's not on the slide.
Stop share and then share the screen and.
Ma'am, share your full computer, share the full screen, not just one video. Share your full computer screen.
Okay, just a minute. Basic. Okay, now just a minute. Is it okay now?
Just a minute. Yes, ma'am. Now it's fine. Thank you.
Now it's fine. Thank you. Okay, so the topic given to me is challenge in the management of MPS. And basically, it's more of a challenge. I would be talking more of a challenge in the management in a very brief 10 minutes time. And when I was given this topic, I started thinking about it and I realized that definitely as of now, if we see the scenario, the Indian scenario, there are a lot of challenges and it's definitely full of challenges because as we saw in the patient testimony, the mother said the rare disease policy is in place, but it needs to be redefined and reframed because it is not effective. So maybe do we have a policy which is not effective, and at various levels we are facing problems as far as management of LSDs or MPS go. So before we proceed, let's look at this case study. So here we had a full-term male child who was born at term, and he was at 10 weeks of age detected to have bilateral inguinal hernias, and for which he was repaired surgically. After that, throughout first years of life, parents had concern because he had recurrent respiratory tract infections, repeated bouts of otitis media, and he was given symptomatic treatment off and on. But till that time, no development or motor delays were noted. However, parents were somehow not very happy. They said something is really wrong with my child, but every time they were reassured. Gradually, this patient started showing some mild facial dysmorphism. There was limitation of the joint movements, and again, parents raised their concerns. After that, over the next 3 years, gradually there was decline in his growth, and with considerable joint limitations and range of motion movements. Then he was also diagnosed with moderate hearing loss, for which he received hearing aids. And now, because of his joint limited activity at the joints and slow growth, the pediatrician referred the patient to pediatric ortho. And the orthopedician noted that child has stiff joints, he has slow growth, he has short stature, facial dysmorphism, hearing loss, and history of frequent respiratory infections. Then he suspected an MPS disorder, and he referred the patient to clinical geneticist. And after that, patient was found to have diagnosis of MPS 2. So look at this. We had this child who presented at 10 weeks of age, and by the time we achieved diagnosis in his case, it was already 8 years old. It was already 8 years. And I'm sure all the panelists here and the audience, those who are dealing with these kind of disorders, they must be relating with this, that we are facing this problem day to day because of diagnostic delays. So when we look at the challenges, there are challenges at every step, whether it's a diagnostic challenge, whether it's a treatment. Once you have started treatment, the monitoring and surveillance, and ultimately the preventive roles. So let's look at the diagnosis. Most of these patients who present with MPS or any other LSD, they are primarily seen by general practitioner GPs or primary care physicians. So it's important to have awareness and knowledge at their level. We as a geneticist or those who are dealing with these patients day in, day out, we are aware of their facial profile or dysmorphology or other manifestations. But usually a general pediatrician or physician may not be aware. So now the thing is, we have to reach at that level. The talks between geneticists may not help much. The geneticists have to talk others. Most of our talks or most of these webinars or CME should be oriented to the general practitioners, wherein these patients are who are primarily attending these patients. And based on, once they have knowledge, they would clinically suspect. And once you have a clinical suspicion, obviously you'll for diagnosis. So another step comes the facility for diagnosis, having lab facilities at each and every step, which obviously these are the things which are on the horizon. And I'm sure gradually in the near future, we'll have more of diagnostic facilities. So for a general physician, when I say, or a pediatrician, when should we consider MPS? So these children could be absolutely normal at birth. There could be, it's a slowly progressive course. And core species is there, but not always, and may be apparent later in life. Corneal clouding is one of the features which one should raise suspicion, but like in Hunter, we don't see corneas are usually clear. And then presence of organomegaly is there, but not always. Maybe the pure skeletal forms may not have organomegaly. Then joint stiffness is one of the features, but if you have a pure neurological variety like MPS type 3, Sanfilippo, you may have purely neurological involvement and no joint or skeletal involvement. At the same bony dysplasias, recurrent respiratory infections or distress, then cardiac valvular disease or previous surgeries, presence of mainly for hernia, tonsils, and tympanoplasty should raise concern that yes, and or maybe various combination of these features when one is encountering. Then think of there's a simple we follow in medical science something called Occam razor hypothesis. Occam razor says that try to fit everything in one diagnosis or try to find out a simple explanation for all the problems. So you have all these things, you cannot have multiple differential diagnoses. Try to fit in everything in one. And so these combination of clinical features should raise concern about MPS, underlying MPS. And remember that there are 11 known enzyme deficiencies, which primarily cause 7 main types of MPS. And when you find a patient of suspected MPS, try to fit in 3 broad phenotype. It could be either visceral plus skeletal. They can also have CNS, a variable amount of CNS involvement. And this includes your MPS type 1, 2, 6, and 7. Then primarily your neurodegenerative features include MPS 3. And we can have primarily skeletal with intact intellectual intelligence, that is MPS 4. So why it is important to have diagnosis, early diagnosis, because diagnostic delays and delay in the institution of treatment will further hamper the disease course and leads to irreversible damage. Look at this SIP pair, wherein in the SIP, one diagnosis was achieved at the age of 3.5 years, and treatment was started 3.5 years. While in SIP pair 2, diagnosis was achieved early in the life and treatment was instituted. So both the SIP pair, as you see, there is a remarkable difference in facial profile as well in the skeletal manifestations. So early diagnosis would result in early institution of treatment, and obviously will result in the improvement and will prevent the irreversible damage which we see in these patients. So a lot of studies have been done and surveys have been shown that there are significant diagnostic delays. Like in MPS 1, it was observed that it was more for attenuated type than a severe type, and patients with attenuated disease were more likely to consult rheumatologists and orthopedists. And on an average, they visit almost 10 times to a general practitioner before they achieve a correct diagnosis. And similarly, this also shows misdiagnosis and diagnosis delays can result in delayed treatment and, as I said, irreversible organ damage, which cannot be corrected by institution of treatment later. A Hunter outcome survey also showed on 639 patients, wherein the age of onset was around 1.5 years, and by the time diagnosis was achieved, it was 3 years, and usually the treatment started at 6 years of age. So between this, the diagnostic delays and there was a onset and institution of treatment was 3 to 6 years. That is obviously too long, because by then we see the manifestations and irreversible damage. So with these as I said, to overcome the diagnostic delays, we have to have awareness, knowledge among the GPs, not only among the geneticists, and obviously more facilities for establishing the diagnosis, enzyme assays, molecular testing. Now right now we are in the era wherein molecular facilities are available, enzyme testing is available, and these samples are picked up from remote areas also in the country. So what it was not there earlier. So as of now, we are better off. Some challenges are being met, but a lot is yet left. So now when come to the management, some of the aspects have been dealt by the previous speakers. So because it's a multi-systemic manifestations, so the management has to be multidisciplinary. I've already, the leading specialist along with your other subspecialists involving the various systems, and with the team of psychologists and social workers, it creates this approach will go hand to manage these patients who have got wide manifestations. The treatments of MPS could be symptom-based or disease-specific. So it is symptom-based, like your hernia repair, tonsillectomy, your orthopedic surgeries. There could be positive vibration maintenance and occupational therapies. Or disease-specific therapies, when we talk about, it includes your, it's enzyme replacement therapies, or maybe hematopoietic stem cell transplantation, which is the standard of care for MPS 1 below 2 years of age. And other therapies dealt by gene therapy by Sunita ma'am, and your nanopore therapies, cellular mediated or pharmacological chaperone therapies, substrate reduction therapies are on the horizon, and I'm sure gradually we are going to see these. But still, though what is available is your, as we know, the ERT is available for MPS 1, 2, MPS 4A and 6, and other ERTs are also there in pipeline now. But where are we as far as ERTs are concerned? Patients are there as a part of charitable access program. Those institutes like ESI, armed forces, or railways, wherein it's on the government, they are able to afford, because patients cannot afford. So these institutes are providing. But as far as I said, the national policy has placed them in class 3A group, wherein there's a long-term treatment the treatment is available, but then long-term it's a costly. So it's a crowdfunding and digital portal. So I think that has to be looked into. These are still challenges. Most of the patients are being diagnosed, but they are not getting treatment. So this remains it's a very big challenge as of now, as far as the management of MPS goes. And once the patient has been put on monitoring, so he has to be evaluated time to time. Your clinical evaluation, including your response to treatment every 6 months, then other neurological, cardiovascular, your spirometry, musculoskeletal, and obviously biomarkers. So these has to be done, and every physician who's treating these patients should be knowing, and definitely it involves the multidisciplinary care. So when we look at the multidisciplinary care in India, where are we? We said that most of the patients in outpatient and around 60% in patient care is provided by private sector in India. It's important. It's not feasible to get all this team together under one roof. But and if you see the public, most in India, the treatment is usually individual based rather than institutional based. So time has to come to move on. The picture is not that gloomy. It's like you have to think global but act local, whatever is available. The lead specialist takes advantage of the technology now, the social media, making the video, sharing with the concerned specialists, arranging for the transportation in the city. If not under one roof, under one city, in one place is there, then all these things can be actually tied up. And so that now the time has come to think of the multidisciplinary care, or even if on the ERT, and value the each, basically keeping this mind that every life is precious and every symptom should be treated, and we have to give them quality of life. Once the treating physician and the lead specialist knows that this is important, obviously they would do anything for these patients. And lastly, about the prevention challenge, genetic counseling, it has already been dealt by Dr. Divya. So we have to counsel, because though ERTs are available, it's exorbitant. We cannot have a family with recurrent problems and with one after the other. So adequate counseling, then prenatal diagnosis, PGD if possible, and obviously the newborn screening for these LSDs or MPS. So LSDs newborn screening has been in some countries, they have started experimenting, but for India, wherein we are still in the nascent stage, and we have programs. So for the basic disease itself, we are screening for 6. In some of the states, we are screening for common, and for extended newborn screening is only offered to those sick newborns. A long way to go as far as screening for MPS or LSD goes, but I'm sure in times to come, we'll overcome these challenges. So to conclude, clinical suspicion is important, but you need lab to make a diagnosis. Effort should be made to diagnose the MPS patient early in life. Identification of the correct type of MPS enables the therapeutic decisions and correct guidance to family. And progression of the disease and response to therapy should be thoroughly monitored. Involvement, multidisciplinary team, and obviously involving the various stakeholders, whether patients, families, and the policymakers, will go a long way in addressing the challenges which these patients are facing. Thank you so much.
Thank you so much, ma'am, for such a nice presentation to actually summarize the end of today's session. And I would, because we have come to an end of it and we are running slow on time, we have lack of time. I thank from my end, and to all the speakers who have been here and all the viewers who have joined in. I will now request Mr. Saurav to please come and give the vote of thanks.
Yeah, it was really a very marvelous talk by all the respective speakers on second day of National Symposium 2022 Care for Rare. I would like to thank all the respected speakers for delivering the brilliant speech. It was really a very knowledgeful speech on the Rare Disease Awareness Day. I wholeheartedly thank our chief guest, Dr. Shefali Gulati, keynote speaker, Dr. Nirja Gupta, Dr. Sunita Bijrania, speakers, Dr. Divya Agarwal, Lieutenant Colonel Aradhana Dwivedi. So now I would like also to my audience who are watching us from different places to please join us tomorrow also, because tomorrow is the last date of National Symposium 2022 on the same link on the same time. Thank you. Thank you so much.